Zolinger Ellison Syndrome is a gastrinoma that occurs in G cells. It causes secretion of large amount of gastrin, causing hyperacidity, increasing the parietal cells, and causing hypergastrinemia. This type of gastrinoma doesn't usually arise from the stomach. Actually, 50% of the cases are found in the duodenum, 25% are from the pancreas, and 25% are associated with the MEN type 1 syndrome. This is the multiple endocrine neoplasia type 1 syndrome, an endocrine tumor that occurs in 3 places. A parathyroid is the most common. 90% of patients with Zolinger Ellison have it. The other 2 places are the pancreas and the pituitary. Let's look at the key clinical features first. The key symptom is abdominal pain. The abdominal pain is due to the peptic ulcers and are usually seen in multiples and can mimic severe epigastric pain. The second most common symptom is diarrhea. The diarrhea is due to mucosal damage by activated pepsinogens from excessive acid secretion. The bile acid insolubility because of this and the inactivation of pancreatic enzymes leads to fatty stools. Zolinger Ellison syndrome may also manifest as symptoms of esophageal pain, specifically GERD, so patients come in with really severe heartburn. The abdominal pain will also come along with a past history of recurrent infections despite treatment. When testing, because the clinical symptoms are so similar to severe peptic ulcer disease, you must rule out H. pylori. Do an endoscopy and a urease test to confirm. Gastrinomas may occur as part of the MEN1 syndrome, and so screening for pituitary adenomas, parathyroid tumors, and pancreatic tumors are important. Parathyroid-related tumors can be screened through a measurement of calcium and phosphorus. An excess of these can result in a history of recurrent kidney stones. The hypergastrinemia can be tested using multiple ways. A gastric hormone test detects the excess production of gastrin. Low levels are not of concern, but high levels usually indicate Zolinger Ellison syndrome or hyperplasia. The basal gastrin test measures the fasting gastrin levels, which will be 10 times over the gastrin's normal upper limit of 100 in presence of a very acidic environment. The secretin stimulation test evaluates the pancreas's ability to secrete gastrin. Patients with gastrinomes will have a dramatic increase in the serum gastrin following the secretin stimulation. Gastrin levels increase more than 200 picograms in 15 minutes of secretin injection. This is the investigation of choice to confirm if patients are diagnosed with the Zolinger Ellison syndrome. Another value is tested. The basal acid output refers to the acid output under basal conditions. The maximal acid output represents the acid output after gastric stimulation. The ratio between these two are taken. The normal ratio is between 4 to 10 millimeters per hour. In patients with Zolinger Ellison syndrome, the BAO is more than 15 and a ratio of more than 0.6 is indicative of the disease. So as a quick recap, check for the past medical history. Do they have increased calcium or recurrent kidney stones? Then rule out PUD or H. pylori. Perform endoscopies to check for multiple ulcers and do a urease test for indication of H. pylori. And for the lab work, conduct secretin stimulation test, fasting gastrin levels, and take a BAO-MAO ratio. Now we need to find the location of the tumor. This is known as a hypothetical triangle that starts from the apex at the junction from the cystic and the common bile duct, inferiorly through the second and the third part of the duodenum, and medial to the junction of the head and body of pancreas. It is known as the gastrinoma triangle. 90% of gastrinomas lie in this anatomical location. So now that we know the location of the tumor, how do we find it? The main investigation is an endoscopic ultrasound, as it has a greater sensitivity in detecting small tumors. You can also do a CT and an MRI. An important pathology is that patients have a significant increase in somatostatin receptors. You can do a somatostatin receptor scintigraphy, a nuclear autorotide scan, which helps with checking for metastasis. For treatment, PPIs are first given. They are the first-line treatment for Zolinger Ellison syndrome. For a patient with already long-standing PPI usage, stop the medication for about 6 to 7 days before doing a secretin injection test. Long-standing PPIs don't influence gastrin level, but it will reduce the acid level, which can give a false negative. Somatostatin analogs, such as octreotide, are given to decrease gastric secretion and is useful in treating the symptoms. Surgical resection is recommended for tumors that are larger than 1.5 or 2 centimeters or localized. For management of metastatic gastrinomas, the initial treatment is given with long-acting somatostatin analogs along with alpha interferon 3 times a week. Chemotherapy with streptozotocin, doxorubicin, and or 5-fluorouracil can decrease tumor size in some patients but don't prolong survival. Usually, PPI is given as a medication for a lifetime. And that's the end of the Zolinger Ellison Syndrome discussion. Thank you for watching.